Congresswoman Michelle Lujan Grisham is serving her second term representing New Mexico's 1st Congressional District. She is a 12th generation New Mexican, has dedicated her life to serving the community, fighting for seniors and veterans, and ensuring access to quality and affordable health care. During her tenure, she's introduced the Health Equity and Access under the Law for Immigrant Women and Families Act, which aims to reduce barriers to health coverage for lawfully present immigrants. She's also worked tirelessly with the Tri-Caucus to pass the Health Equity and Accountability Act. She's a longtime advocate for health equity. The Congresswoman is currently co-chair of the Health Task Force for the Congressional Hispanic Caucus and has worked to engage stakeholders and constituents to push for health reform. So we are excited. And right on cue, in a split second she'll be here. I will also thank Dr. Faith Mitchell, who will then be speaking and addressing us after the Congresswoman. She is president and CEO of Grant Makers in Health, a Washington, D.C.-based philanthropy affinity group that supports and informs the work of health foundations and corporate giving programs across the country. Throughout her career, Dr. Mitchell has bridged research, practice, and policy to improve population health. We thank her for her patience and her willingness to be here today. And without further ado, we are very excited and honored to have Congresswoman Michelle Lujan Grisham join us. Thank you for being here.
Nice.
How's that? Right on cue. Thank you. Please.
All right. Well, thank you very much. Usually it takes me a minute to sort of adjust, but given that I can see over this podium, we're off to a very good start, because that's usually not the case. And I have to be out front. We got to figure it out. I'm really delighted to be here and really excited to see so many folks. This topic should not be a topic, in my opinion, healthcare disparities, particularly when we look at not just access issues for all populations and preventative healthcare in general in the United States, but when you dig a little deeper and think about what we're really doing for at-risk populations, which are primarily minority populations, we should be much further ahead, because the reality is health equity or health justice is certainly not rocket science. And I know that these are all familiar issues to both the students here and academics and advocates, and trying to navigate why we aren't doing better in this country than we are. I think about this one statistic. I thought about it in the 80s when I was running the Department on Aging in New Mexico. I thought about it in the 90s. I thought about it in the 2000s when I was at the Department of Health. I'm much older than I look, I hope people are saying to themselves. Because if you're not, then I lost you all in that very powerful, it's been decades of work. And we were spending hundreds of billions of dollars on diabetes. And that we would have the luxury, not one that I would advocate for, but if I took that 300 to 500, depending upon how you're calculating those numbers, and I reinvested that in just basic preventative care and access, we would have the luxury to make many, 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 many mistakes, more mistakes, in this country in developing a productive healthcare system and investment. And yet, we don't do nearly enough to really address those issues. And I come from a state that has higher than national average negative statistics in terms of diabetes, and frankly, I'm going to go a step back, just basic obesity and having issues with being overweight. And while we see that we'll have some disease management investments that make a difference, if you look at the data around the country and you look at the data in high minority population states like New Mexico, they're short-lived. And a lot of the disease management focus is really a focus on medication management, well after we could have had the right investments up front. And if we go back even a little bit further, which deal with poverty and education and food insecurity, and I can see people shaking their heads, so far I haven't delivered like an equation for rocket science or a new jet fuel. It's stuff that we know that's easy to address if we're dedicated to making a difference in both the educational status and the socioeconomic issues of a population that's really struggling, that causes unfair health issues and really negative, damaging healthcare finance and healthcare policy realities in this country that I would argue today actually are creating more discrimination, not less, as we're struggling with entitlement reform and just exactly where policymakers, particularly in Congress, are really interested in investing their money. And that's really what I want to talk about, because you know all those issues, right? We know that that obesity and being overweight, we know that diabetes is significant. We know that it's the core morbidity issues with heart disease, the higher than national averages for Hispanic populations in particular, but also African American populations with cancer, stroke risks, high blood pressure, that all of that combined means that we're spending incredible amounts of money trying to manage those issues, trying to address those hospitalizations, and still right-size access points that would do two things: deal with folks who we're trying to mitigate those issues for and to prevent those for other folks. And I'm going to do one wonderful stat that we need to be applying to all populations. And I want to really just talk about why aren't we getting it done, and where is Congress, particularly members like myself, where are we trying to engage so that we can actually do what we already know works. So the CDC, for a couple of years, has got a really productive stat showing that almost by half, I think it's 42%. I'm really terrible at looking at my notes, and you as taxpayers pay people in my office to do incredible research and then to write my remarks for me, and then I can't look at them because I have to have glasses on and I can't do it. So I'm completely obsessed with being able to see over the podium anyway, so I just don't even do it. So if I get a number wrong, somebody in the audience should do your job and correct me, or my faithful staff will shake their heads in disbelief once again. And I don't even know where I was actually when I just went off. But 42%. That's right, 42%. So we've reduced childhood obesity by 42%, 43%. In the age groups of 2 to 5. See, I actually had to look at it. You're welcome, Akshay. That's an incredible stat. And so what remarkable investments did policymakers do? What was the difference? Nutrition shifts, right? More breastfeeding, longer breastfeeding, reducing sugar, and introducing exercise to the youngest population. Those three things, and really it's two: sound nutrition, maybe I'll do the three: education for the parents, right? That leads to better breastfeeding results, better nutrition, and exercise by almost half. The likelihood, now that's going to be something I'm interested in terms of health equity. If we manage and maintain those investments with those childhood populations, the reality is we shouldn't be having a conversation today about health disparities in the same way, because we will have created an entire shift in population health in this country. So the stuff that we already know. So what I want to then do, now that I did an actual statistic that I believe is correct with sort of looking at my notes, is talk about what I've learned as my third year in Congress with someone who I don't have a healthcare education. I play a doctor on TV. I learned about healthcare really in two ways: by the seat of my pants as a policymaker, when you would come to me and say, why aren't we making investments in places where it really makes a difference? And why are we allowing the healthcare system to continue to discriminate against minority populations in terms of where the access points are, how we're providing education and support, and recognizing that poverty is still the overarching problem here. The second thing is that in being a policymaker, not having that clinical background, touching the lives in really remote and rural areas. I mean, I come from a state where the challenges are incredibly significant, really call for not just a state aspect, but a real significant federal role, which is frankly why I ran for Congress, to engage and weigh in healthcare reform. And here's what I know today. The way in which we score legislation for preventative health investments is non-existent. So in an environment where we have a raging debate in Congress, not only about where we're headed as a country for healthcare, but how we finance those healthcare initiatives and reforms, including the current financing structure of the Affordable Care Act, that we know that if we invest in prevention, we make the real differences that not only improve the quality of life and the healthcare status of the populations we're advocating for, but it saves real money. And the reality is that the United States has one of the worst public health systems in the way in which it interacts, because that's preventative care and education and what I would call real universal access. Americans don't use public health care nearly in the same way as any other industrialized nation. They may not also have the sort of interesting diversity issues that we have to cope with and embrace, and also we ought to be highlighting those as successes in this country. We're going to have to introduce that. But to introduce that, we talk about shifting our current healthcare investments or adding those healthcare investments. If we have to score everything in a Congress where if we're spending money, I have to show that it's saving money someplace else, right? We're either a budget neutral environment or we're cutting where we're spending money. And for this side of the room who thinks that's great policy work until the deficit's completely closed and this country has no debt, and for this side of the room that thinks that there ought to be a more balanced approach with being smart about our priorities but also investing, the reality is that's where we are in this Congress, right? We aren't going to spend a dollar unless we're taking it from someplace else. And if we don't do that aggressively enough, we're going to keep, I'm sure everyone here knows about the sequester, which means arbitrarily, indiscriminately, we're going to keep making cuts in where we're spending money in this country. So imagine then, if the only way that I can demonstrate that I can get a bill onto the floor is by showing that an investment in prevention will get to the heart of this $300 billion we're spending in diabetes. If they don't know how to score those long-term savings, there isn't anybody in Congress who can effectively make a legislative or policy case in an area that you all have been advocating for the same number of decades that I've been trying to garner the same level of expertise that you do. So that's number one. I only want you to think about that as you have your speakers today, that we've got to shift the way in which policymakers, and I want to really thank the Council of Governments for hosting this, because that's a place where local government can really weigh in and say, we know how to do that. We have to do long-term spending investments, and if we're going to do healthcare, and we're going to do healthcare disparity work, we have to be able to capture the essence of that preventative investment. So that's one. And that's an area, so I'm on the budget committee, and you'd think that that would be a place where organically we'll get that done. Not so much. But I'm optimistic that more and more members of Congress, because of the healthcare spending, they have limited choices about not becoming experts about how we make these arguments and how we change the way in which we do this scoring. Because we don't have those luxuries with the amount of money that we're spending in areas that aren't making a real difference anymore. Two, I'm in a couple of positions where I can advocate for smaller reforms that you are already advocating for. Frankly, I stole all of your good ideas. And so I want to talk to you about how I think we can now advance those in Congress. So one of those ideas is we're going to focus on healthcare education, both by policymakers and by consumers. And we have to be serious about that. And if we're going to be serious about healthcare disparities or minority health disparities, then in your minority caucuses, there's got to be an effort by us to work on healthcare as a priority. And of course, we do that. So the Black Caucus, the Hispanic Caucus, the Asian Pacific American Caucus, we work together collectively on HEA, which is the Health Equity Accountability Act. Now, for me, that's a terrific blueprint that ought to find its way in terms of philosophy into every other thing that we pass. Now, interestingly enough, we can't pass that bill, and it does, in spite of the fact that it doesn't pass, it does get reflected in larger reforms in Medicare and Medicaid, and I'll give you one great example, and in the Affordable Care Act, where we've now created the Office of Minority Health so that we know there's at least a focal point in Health and Human Services. and an area and body of research and grant making that might be able to help us produce the kinds of end results where someone like me can make the case to CBO that investing in prevention is providing the savings that we want, as well as an improvement in the health status of the populations that we're advocating for. And so we're on a new generation of the HIA Act. I'm a co-chair of the Hispanic Healthcare Task Force, and because I only play a doctor on TV, they've required that I have a co-chair who's an actual MD. And that's Congressman Raul Ruiz, and he's terrific. And the two of us, in addition to the basic issues about access, disparity, and equity, are going to focus on two areas that I'm only going to highlight for a second because it'll make me digress, and then I don't know what happens after that. But he's introducing an area of technology which I do believe, like prevention, is a prudent and effective investment. But it should not try to replace a relationship between a healthcare provider and particularly the minority populations in terms of family care. I believe if we focus on a more family care environment, more like the medical home, but where it really works. And in this whole environment with the Affordable Care Act, which I support, not the environment, but the Affordable Care Act, where we're narrowing networks and insurance companies, I think, are actively engaging in adverse selection because they can, again. We went from protecting consumers on pre-existing conditions to, in my personal opinion, to not protecting consumers for adverse selection. That means that the equity issues for minority populations are exacerbated, I think. I think that's absolutely occurring in my state. But as long as we're adding technology, so it's not just telehealth and telemedicine, but it's rather I have a monitoring and families are engaged in a more direct way with really knowing what their healthcare issues are in the moment. That's really important. Now, all the data about folks, and I have one, I'm not wearing it today, but the craze with our Fitbits, it's too early to tell whether we're having long-lasting behavior changes, but the data in for short-term behavior changes is in, and it's good. Now, it's going to be able to translate that, and I think that kind of technology, I agree with Dr. Ruiz, if we can translate that into long-term behavior changes, would be a very cost-effective way to reduce healthcare disparities, particularly in minority populations. So I'll use the Navajo Nation, which one report, and I want to be careful, I'm going to give you the stat, but I can't promise you it's accurate. When we were doing quick research in the car, thank you, Akshay. I'm going to throw you right under the bus. It looks like there is a 77% of the Navajo Nation, as an example, the Native American population is obese and or overweight in New Mexico. I think that's going to be actually a little high, so I want you just to think about that, but it's going to be well over 50%. So maybe to do a better job with that stat, since I can't cite you the source and I can't tell you that it's a credible source, and being that I'm at a university, I should try to do a better job with that. Let's say the range is, it's a bad stat, but between 50 and 70%, that, and it's a population that's poor, doesn't have access to medical homes, to adequate access to health care, transportation, clean water, running water, sanitation. Everybody has a cell phone. Have access to no access or limited access to all of the infrastructure, societal infrastructure that leads to better health quality. But they all have a cell phone. So I do think introducing health technology using smartphones. I should have said smartphone, not cell phone. That shows I've aged myself again. I think I still have a flip phone somewhere in my desk. That we know that we can make an improvement. And then two, I really want to talk about the long-term care investments, because for too much of our minority populations, while we ought to be focused on preventing, there's a reality about the mitigating and the family caregiving dynamics for caring for multiple chronic diseases, where we also have a significant disparity for minority populations who are affected by multiple chronic diseases and don't have any of those systems to provide both the primary and acute care and certainly not the long-term care. So in this tri-caucus world, we're going to keep working on those issues, and I'm excited by that. Two, I've introduced legislation to get at some of the immigrant gaps in healthcare, and that's called the HEAL Act, and it's the Health Equity and Access Law. And what it does is it basically says we should remove all the arbitrary bars that prevent legal status immigrants from having access to healthcare. How many folks here are aware that we've got a 5-year bar to Medicaid, to buying insurance on exchange, to getting access to subsidies for individuals, great, in this country, but for the 2/3 that didn't, these are individuals in this country who are paying for access to those services, but who are barred for 5 years. Now think about that just in terms of the Children's Health Insurance Program, CHIP. If you have a sick child, an acutely sick child, or a medically fragile child, what is the cost to society for having that care delivered in a hospital and in the emergency room because there are no other access points for those families? It makes no sense, and because we're dealing with immigrant families, we're re-engaging in discriminatory practices and creating more disparities in minority health. Third, we're looking, when we talk about all of the energy policy shifts, a reassertion and more education in Congress that when you look at our energy problems in terms of pollution and high risk, our refineries and our waste plants and our wastewater treatment plants are located in minority communities, creating. So we have air pollution issues, water pollution issues. I would tell you we've got soil contamination issues, which I would argue are clearly a problem in having a higher than national average cancer associated and cancer risks associated with more than just our nutritional aspects, but the environmental conditions in which minority families are living in and faced with. And that's an area that Congress has a responsibility to address in a much more significant way, and there needs to be more effective partnerships with local bodies of government who are also part of the problem and absolutely the solution in this design. And so that's an area that we are all working on. And then lastly, on the long-term care side in particular, I'm working on a brand new program called CareCorps, which is a national service idea mirrored after the Peace Corps, but only focused here, where we would take young people, train them to be direct caregivers. They would be on the more unskilled direct caregiving aspect and do companion care, focusing on minority populations with chronic diseases and getting into those low-income communities where we have other healthcare disparities and limited access. And then we'll provide you housing and a stipend. And then for 2 years of service, we will double that in terms of educational credits and to address the high unemployment rates of young people in this country, which are also, I know no surprise to you, hits minority young people harder than it does their white counterparts. We would also pay off student loans. So giving you the opportunity to maybe midway through school or right after school to still engage in a national service project that I think provides not only heightened awareness about these disparity issues and healthcare issues, but engages in a family healthcare support and changes the dynamics between older people and younger people, where in terms of healthcare advocacy, I'm seeing a divide that I don't think is a healthy divide in this country about where we make our investments. So I'm really excited about that, and there's a bipartisan effort in a brand new caregiving caucus. So I round all of this up to say that while they may be a bit disconnected in terms of, are we focusing on education and prevention, better nutrition policy, better environmental justice, where are our funding initiatives going, how is the entire body of Congress working on health care? But if we don't have our toe in the water in each of those places, I don't think we're really going to get to a better health justice environment in this country. And so here's my last component of this, and I'm very happy that you invited me here. I probably should have said that at the beginning, but I'm still happy, is we need advocates who are demonstrating, and I absolutely am going to digress one more time, that we need to be careful that for every advancement forward, if we're not really paying attention to the minority health issues, sometimes it's 2 steps backwards. So I'll use my own state, where we have very poor insurance competition, where we've got significant narrowing of the networks, which means adverse selection, so that minority populations have limited access under the Affordable Care Act, even though New Mexico gets highlighted as one of the states that had the largest double-digit increases in the insurance rates, coverage rates, and a huge Medicaid expansion, which we needed. But where are minority populations getting their health care today? Well, I started by telling you they don't get it in public health investments. We spent more money in community health care and federally qualified health centers. We're not getting it there. They can. Where are they getting it? In ERs, right? So the exact opposite is occurring than what we intended in the Affordable Care Act, say many, many, many experts. Now, we're not so clear how long that trend will continue, but it's a very dangerous trend, and I think it's a factor of those 3 things. We don't have good healthcare literacy in this population, and I've interviewed some folks, even in my own district, who say, I just call the ambulance because it's covered now. No, don't. If you can call the ambulance, that should be one of the tests. If, as the patient, you can call the ambulance, maybe you don't need the ambulance, okay? If another family member is calling the ambulance because you can't speak, then definitely you need the ambulance. Now, that may be a little too narrow a design, but when there's this attitude, and folks don't have transportation. I don't have mass transportation or urban transportation in my state. So if you don't have a car, and you're sick, of course you would call the ambulance, right? How else would you do it? 2, there's no relationships because of healthcare education with a primary care physician or a medical home. And even if you understand that that's necessary to begin to have a healthcare relationship, do you really have access if I just told you that we don't have enough competition, which means we have narrow networks, which means I don't have enough providers, which means I certainly don't have culturally competent providers for a population and a state that is a minority majority state. We ought to have the highest concentration of culturally competent providers in the country, but we don't. And then if you add to that, we can't keep those providers in rural and frontier communities. So now we've even limited access further. We're going to have to really think about the Affordable Care Act and how we're making those investments and what we expect from insurance companies, hospitals, providers, and those networks to make sure that they're creating really communities of health and that they're impacting minority health disparities in a much more meaningful way. And so you have a lot of work to do, and I have a lot of work to do. But I don't want to leave you with the things that don't work. I want to leave you with the opportunities because of your work and ours that are coming. And I think it's clear that this is a country that no longer wants to discriminate. I believe in my heart that we recognize that we haven't done the heavy lifting that we should have done at the front end, that we don't have to demonstrate anymore, that we don't want a population that's chronically ill and that's or spending money in the last 2 weeks of life in a hospital in Medicare. That if we provide the right investments on the front end and we create a family healthcare dynamic, which minority populations function better in a familial environment, particularly Hispanic families, we can not only turn these terrible statistics and this dynamic around. There's no reason in a decade that we can't have other countries learn from the investments that we're making in holistic family care and healthcare support. So I want to thank you again for inviting me here. Apologize to you for walking in and walking out. But I hope that you'll give other members, including me, more chances to come, and thank you for your incredible work and research and an opportunity to be partners with you as we redesign the healthcare system so that we address healthcare disparities and do something about having healthcare justice is the topic instead of injustice at the end of the day. Thank you all very much.